Rank 1, Army medical student, you are 22 years old. The Army is paying for your medical school tuition, housing, a monthly stipend. In exchange, you owe them years of service after you graduate. You signed the contract before you understood what years of service looks like from the inside. This morning, first, or observation. A bowel resection, diseased intestine removed, healthy ends reconnected. You are not allowed to touch anything. You watch on the monitor above the table. The attending's hands move through the procedure without a single moment of uncertainty. 40 minutes. When it's over, you understand, in the specific way you understand things that don't leave you, that this is what you want to do with your life. You don't know yet what you've agreed to. Colonel Marsh, the program director, finds you in the corridor afterward. He says deployment assignments go to surgeons who finish in the top third of their class. You are currently in the middle. He doesn't wait for a response. Rank 2, surgical intern, 4 in the morning. You are checking blood results for 11 patients before the attending arrives at 6 a.m. You are a doctor now. Your white coat has your name on it. You have not operated on anything. Your salary is $58,000 a year, close to 80 hours a week, roughly $14 an hour, less some weeks. You are the lowest person in this building below the attendings, the residents, the nurses, the scrub technicians. Your job is not to operate. Your job is to check labs, fill out paperwork, hold a camera steady for 3 hours while a resident operates, and stay out of the way. The Army hospital is different from a civilian one in ways nobody explained before you arrived. The patients are active duty soldiers and veterans. The attending surgeons have all deployed. They move between operative technique and field triage, the rapid sorting of casualties by severity when resources are limited, in the same breath, the same tone, as if those two things were never separate subjects. You don't know what field triage looks like from the inside yet. You are aware of this gap every time they speak. Third week. A post-operative patient, a 34-year-old staff sergeant, routine appendix removal, no complications flagged. At 2 in the morning, his oxygen drops. A blood clot has moved to his lungs, a pulmonary embolism, where a clot blocks blood flow through the lung and the heart can no longer keep pace. You call the attending. You follow every instruction. He dies at 5:20 a.m. You write the death note. You go to see the next patient. You don't cry. You don't feel much at all. Colonel Marsh finds you in the break room that morning. He doesn't ask how you are doing. He asks what you would have done differently at 2 a.m. You give him an answer. He nods once. He leaves. A fellow intern, Dr. Reyes, sits across from you that night. She says, "The ones who ask what they do differently are the ones who stay. You don't forget it." The weeks after that are the same in the way all difficult things become the same. Labs, paperwork, camera work, consent forms. Occasionally, at the end of a case, a resident lets you close the skin, the outermost layer, the part the patient will see. That's it. That is intern year. Every week, there is a meeting called Morbidity and Mortality Conference. Every surgeon in the department reviews every complication from the previous week, every patient who got worse, every outcome that wasn't planned. Colonel Marsh runs it the way a prosecutor runs a courtroom. In your 6th week, he asks why a specific medication was adjusted on a patient the night before. You were not involved in that case. You say so. He moves on without waiting. The silence is worse than being corrected. Intern year ends. 42 operations assisted. Debt, none. Age, 27. Residency assignments are posted. Brooke Army Medical Center, San Antonio. Level 1 Trauma Center. The largest military surgical training program in the country. You look down the list of attending surgeons. Colonel Marsh's name is on it. You stand there for a moment. You don't know yet whether that is the best news you have received or something you will need to survive. Rank 3, Junior Surgical Resident Year 2. The attending hands you the instruments and steps back. Your first case is primary surgeon, a laparoscopic cholecystectomy, gallbladder removal through small incisions using a camera and long-handled tools. The most common operation in general surgery. You have assisted on it 28 times. Now it is yours. You track the anatomy, the camera angle, both instruments, everything that could go wrong. At some point, the attending leaves the room. You don't notice until the case is over. 80 minutes. No complications. You feel something. You don't have a name for it. By the end of the month, you don't feel it anymore. It is just a case. Then the next. Then the next. You are responsible for the interns below you now. You teach what you were taught 14 months ago. Some of them are faster than you were. You don't say so. Dr. Reyes is in the same program ahead of you in case count. You study together on the nights neither of you is on call. Those nights become fewer. Neither of you says so directly. You stop counting the nights and start counting the cases. The OR is the one place where the math always makes sense. The Army sends a briefing. A surgical team is being assembled for a 9-month rotation to a forward operating base in western Iraq. Volunteers requested from attending and fellow level. Not you. Not yet. You watch the attendings read the document. Most have already been. Some sign immediately, the way people sign things they decided before they walked into the room. Colonel Marsh volunteers. He leaves in 5 weeks. He shakes your hand in the corridor before he goes. He says, "Pay attention to everything you do here. You will need it somewhere that is nothing like here." He doesn't say where. He doesn't say when. End of year 2. Case count, 190 operations. Technical evaluation, strong. Your partner has started making plans that don't include questions about your schedule. You tell yourself that is a reasonable adjustment. You know it is not. A letter arrives from Army Human Resources Command. You are flagged for early deployment consideration at the completion of residency approximately 20 months from now. The letter uses the word voluntary. Colonel Marsh once told you that in the Army, voluntary means they have already decided. They are waiting to see if you will make them ask twice. Rank 4, Chief Surgical Resident Chief Year. 11 residents, 3 operating suites, a trauma bay that doesn't empty between cases. You are operating 4 days a week colon resections, vascular repairs, bile duct reconstructions. Complex cases where one wrong decision compounds into 3 more. You are also still technically a trainee. Nobody outside this building understands what that combination costs. You manage scheduling conflicts, resident complaints, quality review paperwork, and the weekly morbidity and mortality conference. You have sat in that room for 3 years as the person being discussed. Now you help run it. The difference is smaller than you expected. You sleep less than you did in intern year. This surprises you. It should not. Dr. Reyes accepted a cardiothoracic fellowship in Houston 3 months ago. You had dinner the week before she left. You talked about cases. You did not talk about the thing that was actually happening. That is the last time you see her for 4 years. 6 weeks into chief year, a hernia repair, a tear in the abdominal wall, closed with mesh and suture. Before every operation, the team runs a safety check. Patient name, procedure, correct side. You have done this check more than 400 times. You are tired. You are already composing the post-operative orders in your head. You are about to cut on the wrong side. The scrub nurse, a woman who has been in this or for 19 years, says your name. Just your name. You stop. You check the consent form. You check the skin marking. You correct it. You finish the case. You perform 2 more that afternoon. The program director calls you in the next morning. He says the system worked. He says you need to manage your fatigue. He is not wrong. That night you replay the position of your hand for 2 hours. There is no one to tell that to. Residency ends. Written boards. Oral boards, 2 senior surgeons, no notes, crises managed out loud. You pass both. Case count, 830 operations. Debt, none. Age, 33. You have never operated in a building that was itself a target. Deployment orders arrive 11 days after your board results. 7-month rotation. Al-Assad Air Base, Western Iraq. 6 weeks to ship out. The handoff document lists the surgeon you are replacing. Colonel Marsh has been there for 5 months. His rotation ends the week you arrive. Rank 5, Staff General Surgeon Al-Assad Air Base, Western Iraq. The surgical suite is the size of a large living room. 2 operating tables, 1 ventilator, a portable blood bank and a refrigeration unit the size of a kitchen cabinet. A scrub technician named Corporal Diaz, who has been in this tent for 10 months and knows every piece of equipment by feel in the dark. Outside, 112 degrees. Inside, cold enough to keep sterile instruments sterile. That is the only climate consideration that matters. Colonel Marsh's handoff takes 25 minutes. He tells you what doesn't appear in any document, which supply requests run late, which patients minimize their pain until they can't, which decisions you will make before anyone above you is reachable. Then he boards a transport. You are the surgeon now. First week, 3 cases. Shrapnel from a forearm, a ruptured appendix, a hand laceration requiring tendon repair. Controlled. You begin to think you understand what this assignment is. Week 3 changes that. 1:30 in the morning. Mass casualty alert. 4 soldiers, 1 IED strike. 2 stable. 1 with a hemothorax, blood pooling inside the chest cavity, compressing the lung from outside. One with bowel perforated in 2 places, blood pressure dropping, 1 table prepped, Corporal Diaz. 1 flight surgeon with limited or experience, chest first faster to stabilize. You insert a chest tube, a hollow drain between the ribs to pull the blood out and let the lung re-expand. 8 minutes, pressure normalizing. Second table, the abdominal surgery takes 2 hours and 10 minutes. The soldier is 19 years old. He survives. Corporal Diaz hands you coffee when it is over and says nothing. You understand this is how a good night is measured here. Over 7 months, 38 operations, no deaths on the table. 2 soldiers die in the 48 hours after complications that moved faster than the medevac system could. You write both death notes. You go to the next case. You keep the count, so they don't become a statistic before they finish being a person. The deployment ends. You fly home. You sit in an airport in civilian clothes and a man asks window or aisle. You say window. Nobody in that terminal knows where you have been. You don't try to explain it. Age, 35. Deaths you carry, 2. A notification is waiting when you land. A forward surgical position in Eastern Afghanistan needs filling within 90 days. Your name is already on the consideration list. Nobody called to ask. Someone decided and moved on. You read it. You set it down. You already know what you are going to do. Rank 6 Subspecialty Fellow Trauma Surgery, San Antonio Military Medical Center. Trauma Surgery Fellowship, 1 year. You chose trauma because of what you saw at Al-Assad, not because the work was manageable, but because it wasn't. And you had found a way to function inside that anyway. The fellowship director is Dr. Okafor, civilian trauma surgeon, 22 years of practice. The best operative technician you have watched since Marsh. No wasted motion. No repeated instruction. She has never deployed. There is a gap between what she knows and what you have done. Neither of you addresses it. You learn from her regardless. The gap runs both ways. 3 months in, the Afghanistan notification arrives. Not flagged as voluntary. 8-month rotation. Kandahar Role 3 military hospital, larger than Al-Assad, higher volume, more complex injuries. Blast trauma from explosive devices creates pressure wave damage that moves through the body in patterns no civilian textbook covers. You ship out in 6 weeks. Kandahar takes 4 days to fully register. On day 4, you operate for 14 hours. 2 months in, a soldier arrives with severe blast injuries to both lower legs. 2 options. Amputate below the knee 40 minutes, high probability of survival. Or attempt vascular reconstruction to preserve 1 limb longer, roughly 40% chance he survives the table. His blood pressure is 58/40 and falling. 90 seconds before his body decides for you. You amputate. He survives. You write the operative note. You go to the next case. 3 weeks later, a message arrives through the chain of command. His family wants to know your name. They want to write to you. You read it. You don't respond. You sit with it on several nights. You have no words that are both accurate and bearable to receive. So you say nothing. You know that silence is its own kind of answer. Over 8 months, 94 operations, 6 deaths on the table, 4 more in the 72 hours after. You keep the count. Same reason as before. Fellowship completed on return. Board certified in trauma surgery. Age 37. 2 combat deployments. Colonel Marsh calls to congratulate you. His voice is the same. His breathing is slightly different. You notice. You say nothing. He tells you the chief of surgery position at Brook will be open in 8 months. He gave the committee your name. It's yours if you want to carry it. You ask what carry it means. He says you'll find out. Something in the way he says it, not proud, not tired. Somewhere between those 2 things stays with you after the call ends. Rank 7, Chief of Surgery, 7 a.m. Department heads meeting. 14 surgeons, 22 residents, 3 operating suites, a readiness report due to the Pentagon in 6 days. You are still operating 3 days a week. It is the one part of the job where the feedback is immediate. Everything else is the management of consequences, other people's decisions, your own, and the distance between what the institution says is happening and what is. You decide who gets in. You decide who stays. Accreditation reviews, performance documentation, a budget that hasn't grown in 3 years while volume has risen by 1/3. These don't resolve cleanly. You manage them anyway. 14 months in, a malpractice notice with your name on it. A post-operative complication from the previous year documented, reviewed, found non-negligent. Legal process takes 11 months. You are cleared. You think about it most nights for 11 months. You don't discuss that. A second-year resident you recruited personally makes a critical error on an overnight case. He misses internal bleeding on a post-operative patient, not caught until morning rounds. By then, the damage is permanent. The family contacts a lawyer. You manage the process correctly. Documentation complete. Morbidity and mortality conference. Supervised practice pending review. Accreditation preserved. You sit the resident down afterward. You tell him what Marsh once told you, that the system caught it, that he has to learn and keep moving. You watch his face. You were 27 when Marsh said it to you. He is 29. You were in a break room. He is across a desk. You mean every word. You don't know if it reaches him. The distance between receiving that lesson and giving it is something nobody prepares you for. Marsh's absences become a pattern. Late to meetings twice. An excuse made on his behalf twice. A scrub technician pulls you aside. Marsh's hands were unsteady last Thursday mid-procedure. She doesn't know who else to tell. There is a process for this. A physician health program, a confidential reporting system for colleagues whose condition may put patients at risk. You file it. Marsh is suspended. Alcohol dependency confirmed. Surgical privileges suspended. He calls once. 10 days later. He knows it was you. He doesn't say so. He asks how the department is running. You talk about the accreditation review, the fellowship match, a staffing issue. 6 minutes, then nothing. That is the last real conversation you have. He dies 11 months later. Cardiac event. 63 years old. The funeral is on a Friday. You speak. You say what is true about the kind of surgeon he was and what it meant to train under. Someone who still believed the work was worth doing when the institution made that difficult. You mean every word. It is not enough. It is all there is. You implement a resident wellness program. Mandatory check-ins. A confidential support line, peer counseling groups. Participation is low. Marsh spent 30 years building a culture in which needing help and being unable to handle it were the same thing. A memo doesn't undo 30 years. You run it anyway. 3 years as chief of surgery. Age, 43. Or days, 2 per week. A call from a Pentagon liaison. The Army Surgeon General is stepping down in 18 months. A search committee has been formed. Your name was submitted. You did not submit it yourself. Rank 8 military hospital commander. You command a 275-bed military hospital. 1 operating day per month, enough to remember what the room requires. Not enough to stay current. The rest is readiness reports, staffing shortfalls, and the awareness that every decision you delay has a name attached to it somewhere further down. Surgical readiness means, if these soldiers deploy tomorrow, are they fit to go? You sign the reports. You know the gap between what the reports say and what is true. Now you are the one accountable for it. The confirmation process for Surgeon General takes 11 months. Senate testimony. You answer questions about forward surgical capacity, equipment standards, mental health resources for returning soldiers. You have been in those tents. You answer within the bounds of what you are permitted to say. You go back to your hotel and sit with the distance between those two things. Not with anger, with recognition. Large institutions survive by maintaining a gap between what is reported and what is real. They need people who can live inside that without breaking. A readiness inspection reveals a staffing gap, 2 of 4 surgeon positions unfilled in a forward team rotating in 8 weeks. You make 3 calls over 2 days, both positions filled. You don't ask how the surgeons feel about the timeline. You know. You felt it yourself twice. Confirmed. 3 stars. Pentagon office. Staff of 14. 1.1 million soldiers. You have not held a scalpel in 22 months. Age, 48. You think about Al-Assad sometimes. Corporal Diaz handing you coffee without a word. The specific cold of that tent. The cases that came in at angles you couldn't plan for. You don't say this in any meeting. There is no useful place for it. You carry it the way you used to carry the notebook, not to share, but to keep specific. Colonel Marsh's name is on a fellowship endowment now. You signed the paperwork. It felt like the right thing and not enough at the same time. You have stopped waiting for those 2 feelings to resolve. A message arrives from the White House liaison. Your nomination for a second term requires confirmation in 4 months. You read it. You set it down. You call your deputy. You tell him you won't be seeking the second term. He asks why. You tell him it's time for someone who still has full range of motion in both hands. He is quiet for a moment. Then he says he understands. You hang up. You sit in your office. Not because you are uncertain. Because you want to remember what it felt like to make a decision that was entirely yours. Rank 9, Surgeon General of the Army, 8 a.m. A Pentagon briefing on forward surgical team readiness in the Pacific Theater. 12 people in the room. Charts, staffing models, procurement timelines. You ask 2 questions. The briefing changes direction. This is what you do now. You have not been inside a forward surgical tent in 11 years. You remember exactly what the air smelled like. 35,000 soldiers and civilians across 30 installations worldwide. Policy, training standards, equipment procurement, mental health readiness, surgical capacity in every deployment theater. Every number in every briefing has a person inside it. You try to remember that. Some days it is harder than others. The accounting, 32 years of service, 2 combat deployments, approximately 1,100 operations, gallbladders and bowel resections in San Antonio, shrapnel and chest tubes at Al-Assad, blast trauma in Kandahar. Lives saved you can count. More than you expected when you were 22 years old standing at the edge of a room you weren't allowed to touch. Lives that left the tent and went somewhere you never heard from again. More still. 3 patients who did not survive visit you at 3 in the morning. A 19-year-old from Al-Assad. A staff sergeant in intern year whose clot moved faster than anything could have stopped. The soldier in Kandahar whose family wanted to write to you and never received an answer. A therapist named those visits 11 years ago. You already knew what they were. You had assumed for a long time that this kind of weight belonged to a different kind of soldier. It took you longer than it should have to understand there was no such distinction. One marriage that ended not in a single moment but across 100 small departures that didn't announce themselves until the distance was already permanent. One that held a trauma nurse you met at Brook, who kept the same hours and understood without requiring explanation what it means to come back from a place like Kandahar not entirely the same. Children who are adults now. They know you are a general the way they know other facts about the world. Not about you. About the world. Your last day. Retirement paperwork signed on a Wednesday morning before anyone else arrives. Commission surrendered. Medical licenses. Hospital credentials. Without them, you are not a surgeon and not a soldier. You are someone who used to be both. There is a ceremony. Plaques. A framed photograph of the first or team 2 people in it now dead. The rest scattered. A speech from the Secretary of the Army. You smile. You don't feel what you expected. You thought there would be something definitive. There isn't. There is just the room, and then the next morning without it. Somewhere at a military medical school, a 22-year-old is on her first or observation. Scrubs and combat boots. She is watching a bowel resection on a monitor, diseased intestine removed, healthy ends reconnected. The same operation you watched the morning you understood what you wanted. She sees the problem. She sees it fixed. She decides in that room. She has no idea what she has agreed to. The years, the deployments, the patients at 3 in the morning, Marcia's funeral. The silence you kept when a family wanted to reach you and you had nothing to give them. She'll find out. They always do.